Hello and welcome to EEG Station. This presentation will briefly discuss the phenomena of non-epileptic events. Though not a comprehensive discussion, it will focus on some key topics and offer some contrast and comparison to epileptic seizures. Considered the gold standard for such diagnostics, extended video EEG, VEEG, provides streaming data on cortical functioning, which is time-locked to video recording. Anywhere from 10 to 40% of epilepsy monitoring unit, EMU admissions are diagnosed to have non-epileptic events. There are several implications which arise from this statistic. First, there is improved care for those patients who were previously taking anti-epileptic medications, AEDs. Many AEDs have side effects which can unnecessarily affect such patients. Second, there is improved care for patients diagnosed with PNEEs, as there now is a clear pathway for appropriate future care, including consultation by psychiatry and psychology. It is worthy of mention that a proportion of EMU admissions will be patients that have both epileptic and non-epileptic psychogenic events. To the layperson, the kinetic characteristics of a non-epileptic event, NE, may appear indistinguishable from an epileptic seizure. This is, of course, understandable. In fact, even seasoned neurophysiologists may encounter difficulty in distinguishing between the two. This includes events due to malingering, which can include patients who have learned the subtle features for many of the defining characteristics of an epileptic seizure. However, in addition to psychogenic NEs, PNEs, which include malingering and conversion disorder, it is vital to recognize that there are other etiologies beyond psychogenia which may precipitate into an NE. Thankfully, modern healthcare has access to a diagnostic tool which exponentially improves the proper categorization of such phenomena. Also, frontal lobe seizures can mimic psychogenic non-epileptic events due to their deep focus, which results in a poor EEG correlate to the clinical behavior, as well as due to the irregular motor movements which often accompany them. One clue is that if the event immediately occurs out of a state of sleep, then it is more likely to be authentically epileptic in nature. The coupling of video evidence with EEG data is so valuable because it reveals the state of cortical functioning at every point of the event. The video itself reveals the exact features of the episode, including some dynamics which may be more subtle or nuanced. Synonyms for VEEG include CEEG, continuous EEG, and LTM, long-term EEG monitoring. At times, the relatively reduced stress associated with an inpatient hospital encounter may not provoke the patient's stereotypical events, including those of epileptic and non-epileptic origin. AEG can then be utilized. The patient is sent home with a portable EEG unit and their data recorded for approximately 72 hours. Being in their normal home environment is sometimes the key to unlocking the occurrence of an event. However, though AEEG does sometimes include complementary video recording, it often does not. The diagnostic potency of such an EEG is thereby reduced substantially, since time-locked video evidence is not available. And since various types of inauthentic EEG tracings, that is, artifacts, can mimic authentic EEG activity, the absence of video substantially decreases the value of many recorded events. Nonetheless, AEEG without video is still highly valuable, and obviously the better route as compared to no further EEG testing. Several mechanisms which are not epileptic can cause seizure-like clinical behavior and movements. Oftentimes, the movements are benign. Other times, they are pathologic in nature, though not of epileptic origin. Let's first discuss some immediate disqualifiers for epileptic seizure activity. Consider a patient who is experiencing an event in which their entire body, including their extremities, is jerking. If this behavior was due to an epileptic seizure, then there would not be any semblance of a posterior dominant rhythm, PDR. The logic is as follows. For such involvement of the entire body due to epileptic seizure, a large proportion of the cortex would be participatory and affected by the storm of unregulated neuronal firings. This immediately precludes the presence of a normal baseline rhythm, such as the PDR. Continuing with our same hypothetical example, let's presume that during the full body convulsing, the patient is able to answer questions or similarly communicate normally. This would not be possible if the event was due to epileptic seizure for similar reasons. For such a large proportion of body involvement, the direct implication follows that epileptic seizures would arrest the cortex from being able to provide the sufficient functioning required to allow the patient to communicate. With respect to loss of awareness, it is important to note that such focal seizures, as those arising from the temporal lobe and which occur over the patient's dominant hemisphere, can absolutely affect awareness. They can also provoke rhythmic jerking, though the kinetics are confined to the contralateral hemisphere. But aside from the aforementioned disqualifiers, if a concerning clinical event is observed which affects limb movement which is beyond the threshold of a highly confined segment of the body, then we expect to see a time-locked EEG component which is irregular. Some focal aware seizures can cause clinical, repetitive twitching or jerking of a confined portion of the body. This includes but is not limited to a finger, eyelid, or upper lip. To be detected by surface EEG, the involved epileptogenic region of cortex must be approximately 6 to 10 centimeters squared. Therefore, it is quite possible for a patient to be having a focal seizure, though the EEG does not record any abnormal time-locked activity. But if a concerning event is associated with loss of awareness or behavioral arrest, we expect to see something irregular on the EEG, as a relatively large portion of the cortex will be affected if the patient's responsiveness is affected. Rhythmic or quasi-rhythmic jerking of the body must align with specific qualifications to be of epileptic origin. Beyond the EEG correlate itself, distinguishing such an event as either epileptic or non-epileptic can be achieved by a closer look at the clinical features. For example, if the jerking over the right side of the body is not aligned with the periodicity of the left side of the body, then this should greatly reduce the possibility of an epileptic etiology. This is because an epileptic seizure, which causes jerking or shaking of the entire body, will provoke movements which are rhythmically in alignment. In addition, if there are pauses in the jerking, that is, the patient briefly stops jerking and then resumes, then it is less likely to be due to epileptic seizure because generalized ictal cortical activity does not tend to hesitate or pause. Rather, there is a crescendo of activity before the chaotic firings peter out. And when a generalized convulsive seizure does terminate, we expect to see generalized post-ictal voltage and frequency attenuation as the cortex recovers from the extremely high metabolic burdens the seizure has caused. So if a patient has a full-body clinical event of shaking or jerking and then immediately returns to a baseline state in which they are normally answering questions and otherwise interacting in their usual manner, then this precludes the event as being of an epileptic etiology. Here is an example of a psychogenic non-epileptic event. For the first half of the epoch, we see diffuse high-voltage movement artifact. Underlying electrocortical activity is essentially obscured by the artifact. Note that approximately halfway through the epoch, the movement artifact immediately ceases, and the patient's PDR is immediately observed. If the movements were due to a generalized epileptic seizure, the cortex would be in a recovery state, with post-ictal depression of voltage and frequencies. And just a few seconds later, after staff has entered room in response to the patient event button being activated, the patient is unresponsive to questions by staff. However, we observe the clear presence of a PDR, and in addition, we do not see any concerning EEG activity, which is time-locked to the unresponsiveness. This next image is near the onset of the event. During this epoch, the patient was observed on video to be staring off just prior to the onset of body jerking. For such a clinical phenomenon of behavioral arrest or staring off to be due to epileptic seizure, we would expect to see some time-locked EEG change, which we do not see here. In fact, we see a well-formed PDR. Here is the EEG of a different patient who was experiencing a clinical event chiefly associated with intense side-to-side head movements. We can see the diffuse artifact resulting from that head movement. This image is the same epoch, though, with the low-frequency filter set to 6 Hz and the high-frequency filter set to 14 Hz. In addition, the sensitivity has been increased to 3 microvolts per millimeter. Peering beneath the fog of the artifact, we are able to discern a posterior dominant rhythm. But even without manipulating the filter settings, during this epoch, which includes the onset of the event, we can discern the PDR, for example here. There is no evidence of abnormal EEG changes. However, this adult patient was also exhibiting side-to-side head movements. However, notice the abrupt transition from N2 sleep to diffuse movement artifacts, including those arising from head movement. Frontal lobe seizures can be both deep within the cortex as well as associated with faster, that is beta, frequencies. Therefore, surface EEG may not provide any remarkable electrographic ictal evidence. The seizure begins right here. Here is a frontal lobe seizure recorded in a young patient. The seizure begins here out of sleep. As mentioned before, some NEEs are due to etiologies which are not psychogenic in origin. These includes ones associated with cardiac irregularities, which result in transient cerebral hypoperfusion. Here is an example of such a cardiac-provoked non-epileptic event. Specifically, this is an example of torsades de pointe. This epoch is just before the cardiac irregularity materializes. Here is the next epoch, which records the initiation of the ventricular tachycardia. Note that the ECG reflects alternating polarities along the x-axis. For example, during the next epoch, we see the continuance of the unproductive cardiac rhythm, as well as a dropout of the faster electrocortical frequencies. The theta slowing very briefly decelerates to the delta band before the entire background drops out to align with generalized suppression. Before the patient became unconscious and all movement ceased, the patient indicated that one of their episodes was beginning. Then, a rhythmic upper extremity flailing as well as upper body rocking were observed. Upon first inspection, one may have understandably reasoned that this was consistent with a psychogenic event. However, thanks to both the single-lead ECG as well as the EEG proper, it was quickly discovered that the patient's events were caused by this insidious cardiac irregularity. Thankfully, the patient was successfully treated shortly thereafter. The next epoch reveals diffuse heavy EMG artifact along with continuous background suppression. The cardiac arrhythmia continues. Same for this next epoch. We see the same tracings during the first 2-3 of the next epoch 6, though at the point marked here, we see the cardiac rhythm restoring to a pre-event state. The next epoch 7 shows the continued reemergence of a productive cardiac rhythm, though not until this point, marked with the arrow, does the cardiac rhythm settle into a benign state. Shortly after, as can be seen here, reemergence of electrocortical activity precipitates. The initial frequencies are in the delta and theta bands. In the next epoch 8, we see continued reemergence of the EEG background along with diffuse movement artifact as the patient recovers awareness. Here is the next epoch 9, which reveals continued improvement of the background. Beta frequencies are now apparent. Here is the next epoch. Finally, we see the entire ECG sequence encapsulated. The torsades de pointe event occurred from approximately here to here. Below the ECG channel is the quantitative EEG tracings. Note the abrupt dropout of electrocortical activity across all frequencies, starting here and lasting until here. Also note that the faster frequencies are the first to fade, and those same frequencies are the last to be restored. The abrupt dropout of the patient's EEG proper is time-locked to the disappearance of a productive cardiac rhythm.